I am Dr. Deepak Chaudhary, Principal Director and Head, Arthroscopy and Sports Medicine Department at BLK Max Hospital in New Delhi. Today I will be speaking on bucket handle tear of the medial meniscus. So very often we encounter these injuries to the meniscus along with an ACL deficient knee. So why repair the meniscus? Because meniscus has got very important functions on the knee, and that is for load transmission, to minimize the contact stresses. It contributes to the stability, and moreover it has a chondroprotective effect. For all these reasons, there has been a trend in recent years to repair the meniscus as far as possible. What are the effects of meniscectomy? Meniscectomy results in increase in the local contact stress areas, and after 65% after partial excision and to 35% after complete excision. So what are the considerations that you must consider before undergoing a meniscal repair? The important things are the location of the tear, the configuration of the tear. The better the meniscus is in the red zone, the better are the chances of healing. The configuration, if it is a longitudinal tear or a bucket handle tear, the chances of healing are better. Length of the tear, the greater the length of the tear, the lesser are the chances of healing. Again, how much it affects the stability of the knee joint, and whether it's an acute tear or a chronic tear, and what is the age of the patient. Younger the patient, the better are the chances of meniscal repair to be successful. So the basic principles which must be followed in each and every repair are that you have to anatomically reduce the two ends of the meniscus, torn ends. There has to be augmentation, biological augmentation in the area, whether you achieve by using a shaver or a rasp or doing needling. The purpose is to increase the blood supply in this area so that meniscus healing is better. And then there has to be circumferential compression. So these are the three ABCs of the meniscal repair which must be followed in each and every case. Another important technique to reach the meniscus on the medial side is the pike crusting, in which the medial MCL is gradually lengthened. So this makes our approach to the meniscus possible. Otherwise, in a very tight knee, you might damage the cartilage while repairing the meniscus, and which will defeat the very purpose of meniscal repair, which is chondroprotection. So this pike crusting should always be done, especially in a tight knee, so that you can approach the meniscus without causing damage to the articular cartilage. Another important thing is to do bone marrow stimulation, so that some growth factors come in and promote healing. If there is an associated ACL reconstruction, you don't need to do this marrow stimulation, since you are already making tunnels. But if it's an isolated case of meniscal repair, the bone marrow stimulation must be added. So we present a case of a 24 years old male who presented to us with a twisting injury while playing football of the right knee. He was complaining of pain and instability since then, and repeated lockings. On examination, the Latchman test was positive. There was medial joint line tenderness. The McMurray's test was positive, and the knee was locked in 20 degrees of flexion. The collaterals were intact. The MRI findings confirmed that there was an ACL tear, as well as there was a bucket handle tear of the medial meniscus. So this is the surgical video of this patient of a bucket handle tear. As you can see, this is a locked bucket handle tear displaced into the intercondylar notch. And after pike crusting, the first step is to check the reducibility of the bucket handle portion, whether it can be reduced or not. Another important thing which you can notice is that this patient, this bucket handle portion has a cleft. So there is a possibility of a transaction of this bucket handle portion, and if this transaction takes place, then the chances of repair become quite remote. So the basic principles before any repair are to clean and shave the meniscus so that you promote local vascularity in that area. This is achieved by a combination of shaver, rasp, and then by needling. So you must spend some time while preparing the meniscus so that you get a good bed where you can repair the meniscus. So these are all the techniques. And now we are using all inside repair in this case, where the two anchors are are inserted on the two sides of the torn meniscus, and as you tighten the thread, the two ends of the meniscus are brought together. So the basic principle is, for every two superior repairs, one has to insert one inferior anchor so that there is equal distribution of forces. Otherwise, if you just put the superior anchor, the lower side of the tear will open up. So you have to achieve a compression all around the torn meniscus, and this is by a combination of anchors which are placed on the superior and the inferior surface. So the basic principle is that these anchors must be placed at a distance about 4 to 5 millimeter to achieve uniform compression and to make a very robust type of repair. So we frequently have to use sometimes 8 to 10 anchors also in a case of bucket handle which is extending quite anteriorly. So at the end result, you can appreciate now this is a very robust type of repair of the bucket handle using all inside anchors. This is the post-operative CT images. This patient had an ACL also. So as you can see, the tunnels are in right anatomical position, and the follow-up MRI shows good healing of the meniscus as well as the ACL. And this 18 months follow-up shows good meniscus healing, as you can see. So in conclusion, save as much meniscus as possible, and always remember the ABC of meniscal repair, that is the anatomical reduction, the biological preparation and augmentation, and circumferential compression. Thank you. And so this is the patient post ACL and meniscus repair at 1 year. He is quite happy. He is a Bhangra dancer, professional Bhangra dancer who has returned back to his profession. Thank you very much.